Hello. So the year now is 2015. The world population is increasingly becoming a larger number of people. And over the last century, the life expectancy has dramatically increased. The topic that we would like to discuss today is, the rights of older people. And we would like to focus on ethical and legal issues and some policy-related matters. And this is done as a part of our preparations for the 21st Annual World Congress of the World Association for Medical Law, which will be held in Coimbra, Portugal on August 2015. And one of the major topics of this conference will be aging and health law. With us today is Professor Israel Doron. Hello,
Hi.
Israel.
Hello.
Professor Israel Doron is the head of the gerontology department in Haifa University, is a past president of the Israeli Association for Gerontology, and founding member of the Society for
Law in the Service of the Elderly.
Law in the Service of the Elderly. So we will talk about all that today. Thank you for joining us.
Thank you very much.
So basically, I wondered why is older people an academic and a practical issue nowadays, and perhaps you could give us some examples of why it's so important.
Well, as you have mentioned, I think in the last century we have been witness to a demographic revolution, so to speak. Traditionally and historically, the older population consisted a very small part of the human population. The common demographic pyramid was a very large number of young people, children, a significant number of adults, and a very small top of older persons, which again usually lived until the ages of 60 or 70. Mm-hmm. In the last century, as you've mentioned, we've seen a dramatic shift in several demographic elements which totally changed and are changing the landscape of the human demographic. On the one hand, we've seen a significant growth in life expectancy. People are living much longer than they used to be. We almost doubled the average life expectancy. 150 years ago, the average life expectancy was about 40, 45. Today, we are beyond the age of 80 in some places. So that's on the one hand. On the other hand, we have seen a significant decrease in fertility rates. So this combination of low fertility rates on the one hand and very high life expectancy on the other hand, along with a very unique phenomena which is called the baby boom, the vast generation of kids who were born after World War II. So we are now going to experience a revolution in the demographic of the world. And if I can exemplify it, what we used to see as a pyramid, we now see as basically a shape of a rectangle.
Yeah, so the shape has changed, and
the shape has changed dramatically.
Much more people that are elder?
Yes, so we have many significant numbers of older people. Their proportion in the society is significantly larger, and this is something that never before in the history of humankind, it never existed in the way it's going to exist.
So apparently there are many issues that are related to what you've just described. Your training is in the legal field, as far as I know.
Right.
And you've written about what was called in the past elder law,
right,
and ethics and the elderly or the older people, dementia and ethics and the law. So you've written extensively about those fields. Perhaps you could give us some notion as to what are the main issues that are related to health, or not just health, but age and the law, and then specifically maybe what are the medically related issues in this field?
Okay, let me first say a few background notes to begin with. In general, until 3 or 4 decades, law as a discipline didn't have much interest in aging as such. By the way, unlike medicine and geriatrics, which aging and the aging process in the last 2 or 3 centuries was very much as part of medicine, biology, and research in that field. However, within the discipline of law, aging and aging process or rights of older persons commonly was not viewed as something interesting. There was not much interest. There were not many people who studied or researched this field. Mm-hmm. In the last 2 or 3 decades, this has changed dramatically, especially in North America. In the last recent years, also in Europe and other places around the world. So I'm part of a shift within the discipline of law, where legal scholars who are interested in law and society or human rights have started to look into the interaction between law and aging. Now, within this broad shift or interest of law, human rights, and aging in older persons, one of the most significant topics or one of the fundamental human rights of older persons is the right to health. Mm-hmm. So we start with starting to conceptualize and understand what do we mean in the human right to health in the context of older persons.
So it may be a little bit different than just the general topic or concept of the right to health.
Right. So you begin with the general notion of right to health, both on its negative or freedom elements of informed consent or the freedom to choose your physician, mm-hmm. or the right to refuse treatment. And you move to more positive social notions of the right to health, the duty of the state or the society to fund or provide healthcare services. Mm-hmm. Now, each of these dimensions have unique elements or implications for older persons. So, for example, within the positive social right element, for example, the whole issue of the human right for long-term care in old age or institutional long-term care. For example, here in Israel, while we have a universal healthcare program and universal coverage, within this program, this human rights, social rights, we don't have the right to institutional long-term care for older persons. So while a person can have varied basket of health services, yes, which he is entitled to receive as part of his right to health,
which is covered by the insurance,
by the social insurance, yes, under Israel national health law,
yeah,
the right to institutional long-term care does not exist. And once you are an old person and you are in need for institutional long-term care, you don't have this social right. So we see that there is specific elements within the right to health in old age which has some specific elements. Right. So, for example, other issues with regard to the right to health, for example, palliative care, for example, the right to dental care, for example, issues about preventive medicines. These are issues which are crucially relevant to older persons, but are traditionally not covered within broader national health insurance programs such as in Israel.
So basically, this is not merely just a legal question, it's a policy-related issue, and it may relate to lobbying or the power of the elderly, of the older people, to pressure the decision makers to move funds towards the elder instead of, I don't know, the young or the cancer patients, or, I mean, is it this kind of discussion that you're talking about?
Yeah, you are touching exactly on one of the key elements which are unique to the field of elder law. I will call it ageism, which, similar to sexism or racism, is a social construction of old age, mostly a negative social construction of old age. So what you call the political element of power relationship, I think mirrors itself within the right to health or rights of older persons in general, in the sense that if you have a social stigma or social stereotype that older people are less deserved than other parts of the population, the outcome can be in prejudice, in discrimination, in implication which harm, infringe the rights of older person in general, and in specific in the field of right to health, discriminate older persons or older patients within the context of their right to health. So, for example, we have various historical and legal examples on how ageism influences medical treatment which older persons received or did not receive. So, for example, in the field of dialysis, in nephrology.
Yes.
In some countries in the world, until not too long ago, if you were beyond a certain chronological age, so for example beyond the age of 60 or 65,
Yes.
you were not entitled to receive dialysis.
So you would die.
You would basically be prevented to receive a life-maintaining or life-preserving or life treatments that could save your life. Yeah.
And does it make any sense that you could think of, or is it completely senseless?
The question if it's senseless or not is the question of why and how you base your decisions.
Yes.
If you base your decision making solely on chronological age, then it's senseless. It's irrational. It's stereotypical.
Right.
Because two people or more in the same chronological age could be on totally different scale of their health and biological dimensions. So excluding a whole group of population solely on their chronological age without examining their individual characteristic is in many ways similar to racism or sexism by the way that you judge and value a person on a sole characteristic which is irrelevant to the decision which is relevant to be made.
So basically, if I create a correlation in my mind between age and capacity, I'm doing something completely wrong. I could be 32 and incapacitated. I could be 94 with my full capacities. Is that where
you're
going?
Absolutely right. And in this point, I would like to stress, it's not that I'm trying to make some kind of idealization of age. We have empirical research that shows that there is some correlation between rise of chronological age and illnesses. However, when you move to the individual level, you can find a 95 or 85-year-old man or woman, which is she or he are very healthy. And on the other hand, you can find a 35 or a 40-year-old man or woman who are very sick or ill. So preventing medicine or allowing medicine or entitling a person solely on the chronological age without examining other relevant issues is humiliating, is discriminating, is prejudice.
Yes.
I will give you an interesting example here in Israel, two examples that are recent in Israeli context. One is organ donation. Until very recently, heart, liver, and other organs, people beyond a certain age were not entitled to receive organ donations totally. Again, regardless of their physical condition. And the mere fact that you reached a certain chronological age prevented you and excluded you from being able to become one of the people who are potentially able to become the subject of organ donation.
To receive an organ donation?
To receive, yes.
The recipient of an organ?
Exactly, the recipient, to become a recipient of an organ donation, which again, as you said, was to some extent a death sentence to those people.
Yeah.
However, very recently, after a specific new commission was established by the Ministry of Health with professionals and experts within the field of organ donation, this barrier was removed exactly because of this understanding and empirical knowledge that chronological age per se is irrelevant to the decision whether a person should or should not be the recipient of donation of an organ.
Right.
A second interesting example is blood donation. And this is not being the recipient of blood donation, but actually to donate blood.
Yes.
We had a very interesting case of a physician, a geriatrician, Dr. David Cohen here in Israel, who reached the age of 70. And when he came to the blood donation center, they told him, we are very thankful, but we cannot receive your blood because you reached the age of 70.
And reasons were?
That under current guidelines of Israel Blood Bank, they did not receive blood of persons beyond the age of 70.
Right.
Now, interestingly, when you try to examine the rationale and you look into empirical research, you find very quickly that there is research that finds that chronological age is not a barrier to donate blood. The blood itself, on the one hand, and the risk to the person himself or herself are not greater than any other person in younger ages who is healthy or does not suffer from specific illnesses.
Basically, this is like a random decision that is based on prejudice. Is that what you're trying to tell us?
So ageism, or the negative social construction of age, which infects directly older patients and older people within the healthcare and medical setting, the outcome is that older patients in hospitals, in medical care, in guidelines, in legal rights are experiencing discrimination when they are coming to receive the right to health.
Right. So basically, if we are creating more awareness to that existence of such prejudice, or the possibility of the existence of such prejudice, we may advance something within our healthcare system, if I understand correctly.
Absolutely. We can change the experiences and the health itself of older persons. And this touches to another critical issue and point about rights to health and medical law, which is specifically relevant to older persons, is the dying, and dying with dignity, and our ability to talk about death and the experience of older persons when they are at their last stages or the stage of end of life. And the ability to plan your death, the ability to talk with your physician, the ability and the right to receive palliative care, the ability to make advanced directives, and to fulfill your preferences regarding the last stages of life are very important to older people.
Yeah. So concerning, the last stages of life, I know you've written about this topic with others and edited a book on dementia and the law.
Right.
So given that dementia is becoming quite, I'd say, prevalent, and many people over the age of 80, 85 show symptoms of different kinds of dementia, what would be the ethical or maybe even the legal way to look at that? You talked about planning. What tools do the elder have to try to prepare for, maybe not the worst, for this possibility of having their cognitive abilities gradually being harmed?
Well, you can approach it from two directions. One direction would be a preventive approach, which is mostly based on autonomy, informed consent, and the notion that as an autonomous person, we have a duty to respect one's preferences, and to the extent that a person has expressed his preferences, they should continue when he or she loses their capacity. So any person who is diagnosed or not diagnosed, even at younger ages, who wishes to look forward and to think what will happen if I will lose my capacity due to dementia, Alzheimer's, or similar, then I can plan in advance. I can make advanced directives for healthcare, I can make durable power of attorneys, I can make what is called living will or other legal documents, which essentially allow me, as long as I'm capable or cognitively able, to prepare, express directly what are my preferences and wishes. And once I reach that point, then the society, the medical and care experts and care people should honor and respect my preferences.
Yeah. So isn't that a little bit of a kind of an 80s discussion that began maybe in the end of the 70s or beginning of the 80s in the United States, where this topic of the living will and so on was discussed, and the President's Commission discussed it and so on? Isn't that already kind of agreed upon?
Right. But usually that was the case. It was interesting because those cases were relative for younger people in cases of cancer or stroke or permanent vegetative states or issues that suddenly people totally change their mental and cognitive condition.
Yes.
The discussion within the field of old age and dementia is relatively newer because the awareness to dementia and its consequences are a little bit different. So that's one approach. The other approach, which is very interesting, and raises very interesting ethical and conceptual questions, is the whole issue of supportive decision-making, shared decision-making, care environments which allow people with dementia. And one of the fascinating issues about dementia and Alzheimer is that it's not your usual binary approach of at one point you are legally capable or competent, and the next day you are incapable or incompetent.
Right.
It's a very complex gray field that people very gradually lose some parts and some elements of their cognitive ability,
yes,
but maintain abilities in very diverse areas. So the challenge is how to maintain, how to support, how to provide a supportive environment, a legal environment, which will enable people with dementia to continue and make decisions with support, despite the fact they're already into the process of their dementia.
So I think this relates to something that we discussed earlier. Before this discussion, that we had like a pre-discussion, and you told me that, you know, sometimes the healthcare system is not completely accessible to the elder people for simple things like, I don't know, internet access may not be as easily used by older people, or phone systems are not that accessible. So basically, it's not only about people with dementia, is it? It's about creating more accessibility that takes into account different or variable different levels of I don't know, cognitive abilities. Is that
right,
something you think we should change somehow?
One of the key challenges we have within the field of rights of older persons in general and the rights of older persons within the context of healthcare is the gap between the law on the books and the law in reality, or the gap between what in theory older persons are entitled to and what they actually enjoy. And this relates to the association of law in the service of the elderly and the activities we are doing. I think empowerment and education and knowledge production and enabling older persons to, first of all, be aware of their legal rights, to know what they are entitled to do, and then to assist them in actually enjoying the rights that they deserve is a challenge all over the world. So although in Israel, for example, we have a relatively new law of the Dying Patient Act, which has included, for example, a mechanism of advance directives.
Yes.
In reality, the vast majority of older persons are not aware of their legal right to prepare advance directives. Even when they are aware of their legal right, they don't know how to do it. How do they access the form? How to fill the form? Once they fill the form, who do they send it to? Who has to know about it? So there's a whole project and challenge of educating, of empowering, of representing, and assisting older people to be aware and to exercise their legal rights within the framework of the right to health, which, again, in Israel and in other places around the world, there is a huge gap in this field.
Yes. So you're basically now mentioning the activities that you are doing here in Israel as a part of the Society for the Legal Support of the Elderly, or
right,
the name that I keep forgetting. But also, I think you have just founded the legal clinics in the law school,
right,
at the university. So what are the main activities that you are planning to do or you're already doing?
So like you mentioned, only this year we have established a new legal clinic here at the Faculty of Law at the University of Haifa. The legal clinic is specifically aimed at promoting and advancing the rights of older persons. Now, the activities of this legal clinic is very diverse. First of all, it's educating a new generation of young lawyers and young legal scholars to be aware and to have the professional knowledge within the field of elder law, the rights of older persons. Secondly is receiving complaints from older people and providing them legal aid, legal knowledge, legal representation. Working a lot with public education, giving lectures in nursing homes, in assisted living facilities, to older people in the community, to family members who provide care to older family members. So educating professionals and older people about their legal rights. And finally, searching for strategical cases, taking critical legal cases to the Supreme Court or to the court system, and trying to use law as an instrument for legal and social change within the court system. So I will give one small example of a case that we treated quite recently. It was about an older woman living by herself in the community with mild cognitive impairment, receiving in-home care, quite poor, under a formal guardianship of a public body. At a certain point, she ran out of private finances and didn't have enough money to pay for this private care in home.
Yes.
So the public guardian decided that the solution was to move her into institutional care, because if she is poor, she can be moved to institutional care under the funding of the Ministry of Health. Because in Israel, if you don't have any resource and you are poor and you stand up to a needs test, you will receive funding for institutional care.
Yes.
However, if you're in the community, the government will not pay for your care within the community.
So basically, it's encouraging people to move out of the community to be institutionalized.
Right. Against their own will.
Yes.
This case was brought to the clinic and to the Association of Law in the Service of the Elderly, and we filed a claim to the court asking for injunction to prevent the institutionalization of this woman against her will, because it was infringing her basic human right to dignity, and from a financial and policy perspective, it was less expensive to the state of Israel to fund her within the community than to maintain her in an institutional setting against her own will. Eventually, there was no verdict given and no formal decision, but after we filed the case to the court, the Ministry of Health and the Ministry of Welfare established some kind of a solution to maintain her within the community, and found a solution. However, conceptually, this issue of dilemma, of policy and legal dilemma, which basically, like you said, encourages institutionalization of older persons against their will and against their good and rights, based on this policy financial framework, which provides funding for institutional care, but does not provide the same funding for community residential or community-based care in Israel.
Yeah, so basically what you've described, I think, alludes to the importance of having a body that would do advocacy work for different groups, and thinking about, for instance, people with disabilities. You may sometimes assume that if nobody would promote their rights, they may not be empowered enough to do it for themselves. And this may be similar in some way, I think, to the concept of elder law, although it's a very big group of people. Perhaps if they're not empowered and they do not get such a group to support them and to fight the fight, it may not be done. So it's really inspiring to hear about that and to see the connection between academy and practice. Thank you so much, Isai.
Thank you.
For
Thank
this
you very
talk.
much.
And thank you for listening. It was just some examples of the importance and relevance of the ethical and legal issues that pertain to the field of age and ageism. And we invite you all to participate in the 21st Annual World Congress for Medical Law, which will be held in Coimbra, Portugal in August 2015, with one of the major topics discussed, aging and health law. Thank you. Goodbye.